So up next, and thank you to our panel, that was terrific. At RAAP, we've been looking at how can we bring a more integrated approach into patient access, and of course, working with our partners like Every Life Foundation and others, give us those opportunities. So we're very grateful that they were able to be here and talk about the importance of genetic testing and newborn screening because it is so critical. Our next panel, our moderator is Jeff Myers. Jeff is the head of payer relations at Curafi, and Jeff will be moderating a panel to look at a lot of the state policies that have been charging through the states over the past year and exploring some of those areas. He has a terrific panel for that, and so I'll turn the time over to Jeff, who will introduce his panel.
To talk. Can you all hear me? Can you all hear me? Yes, good. Thank you all. I know it's getting late in the day. We've got a lot to talk about around what's going on in the states. We're going to skip for a second discussing RDACs and PDAPs. That's for the next panel. So we're going to talk about just the interesting stuff. I have a fantastic lineup of folks that you can hear from, so I'm going to turn it over to each of them to introduce themselves and give you some background on their. Go ahead, Patrick.
Yep. Good afternoon,
There you go.
Good afternoon. My name is Patrick Plues. I'm Vice President for State Government Affairs at BIO. BIO is the trade association that represents the biotech industry. Many of our companies are rare disease therapy companies. We also represent some of the large biopharmas as well. Our membership ranges from the large companies like Merck, Genentech, Lilly, Pfizer, all the way to small startup one or two research level biotech companies.
Hello, my name is Melissa Horn. I am the State Legislative Affairs Director for the Arthritis Foundation. So cover all 50 states, lucky me, as well as DC and the territories. So a lot of the work that I do surrounds rare disease professionally, but I also am a 3-time cancer survivor myself. So have been through a lot of this myself in terms of navigating access to care. I really enjoyed the last panel with a different conversation around diagnosis and how long it takes. Certainly have experienced that delay. But also whenever it comes to accessing treatment and just, from one cancer to the next, experiencing the long-term side effects of having a chronic disease. Usually it's not in isolation and it's multiple chronic diseases at a time. So I like to try to apply my experiences personally into my professional advocacy in representing those that face chronic diseases like arthritis, over 60 million Americans, the leading cause of disability in the nation, whenever it comes to state policy change. So that's a little bit about me.
I'm Mac Haddow. I work with RAAP as a government relations advocate for rare disease patients. I do a lot of work in the federal and state governments. I was formerly the campaign manager for Orrin Hatch, worked for him for a while. After he was elected, I served in the state legislature. I was the chief of staff at HHS under Reagan, and for a year, the acting administrator of HCFA, and have since been out in the lobbying business for decades.
My name is Jeff Myers. I'm the former head of the Trade Association for the Managed Medicaid Plans. Did that for 5 years, and I'm now the head of payer relations for a venture-backed startup that's looking to make access to high-cost, low-use rare disease drugs easier for state Medicaid programs through both a reinsurance policy and a significantly better PAUM structured program. So let's talk a little bit about the states, because to me, the states are probably the most interesting area around healthcare in the U.S. because they're in a unique position. They are a payer, both in Medicaid and coverage of their state employees, and they're also a regulator around the way in which private insurance and health systems work in their states. And this gives them a very unique opportunity to put their thumb on the scale and move things around. And given the challenges that we have at the federal level to do things like, fund the government, it becomes more and more important that states become the leaders of innovation in healthcare. And there's a lot of stuff going on in states that directly impact access to rare disease products. It is not lost on many of us who've spent a lot of time in Medicaid that states have a variance in both knowledge and resources to actually address these issues. States like California and Massachusetts, where there are large intellectual capital and drug and biologic development, have a very different view of how to cover and access than states that may not have any health systems that function as a center of excellence, like states where I'm from in the South. That means that it is important that the state's efforts around insurance regulation, the regulatory side, and the payer side come together to address some real inequities for access to rare disease products. And so let me first talk about the private and commercial side effort, the yin to the yang of payers. Using insurance regulation, states can affect the way prior authorization and utilization management is done in their state, and the way insurance companies can use step therapy to limit access to innovative therapies. So I want to first turn to talk a little bit about the efforts that Melissa has been doing to talk about step therapy and impacts at the state level and the way states have addressed some of the challenges of getting access to these drugs. So let's have to you.
Sure. So step therapy, prior authorization, there's been a lot of reform discussion amongst the states, and we've had a lot of progress. The Arthritis Foundation is a member. I'm actually the treasurer this year for the State Access to Innovative Medicines Coalition, which is its own C4, and that predominantly focuses on step therapy reform. We have over 30 states that have passed reform in some way, and that includes a lot of addressing the barriers whenever it comes to the process of step therapy, the appeals, how long it takes, and really, kind of this whole mantra of having your insurer, your provider, kind of face this battle over who owns the prescription pad. So in my own personal experience, it's pretty frustrating whenever you're trying to find a drug that will work for your body. Every body is different. Just because you have the same diagnosis doesn't mean that automatically you're going to have the same drug that works for you. I think it's interesting that we talked about biomarkers. A lot of testing can be for diagnostic purposes, but we're also pushing legislation to find better treatments. Precision medicine, in my opinion, is really the future. And, investing in that makes total sense, especially whenever it comes to step therapy. You often, for arthritis, for example, have to fail 2 or 3 times before you can become stable on a medication. And a lot of this is regulating pain and swelling and your mobility. So it's no surprise that you can become disabled and no longer able to move the way that you want, work, participate in your community, and really live a productive life. I always think the goalpost for finding a cure is the wrong one. It's really about having a quality life for the chronic diseases that we're talking about. If a cure is possible, that's awesome. For those that are living with chronic disease, though, it's all about, again, that measurement of finding the right drug that will work for you for the longest amount of time. And when you have these insurance barriers, like step therapy, where you're constantly having to fail on drugs, even though your doctor has indicated that this one might work better for you, it's just really frustrating that you have to go through kind of that pain to find the right drug just because your health plan requires it. Then enter in these changes. Let's say you switch jobs, or some other significant event in your life happens where you change insurance coverage, and you have to repeat those processes. You already know what happened, but because it's a different company that's managing your health plan, you have to once again prove what's going on and what's working for your body and not working. It's the same thing with prior authorization. I'll give you a personal example on this one. So I am a lymphoma survivor from high school. Because of the high dose radiation that I had after chemotherapy, it caused breast cancer in 2017 for me, as well as thyroid cancer in 21. So I had my thyroid removed. Obviously, it's not growing back. So I get to take a pill, a Synthroid, every day to make sure that my hormones and metabolism, heart rate, everything is functioning, because your thyroid, that little butterfly, controls a lot in your body. And that Synthroid can be very sensitive. I've changed this medication 15 times in 2 years. And every time I change it, it's a different dose, because it can be very sensitive to that. And it turns out I'm allergic to the generic because of the tablet coating. So the rate of release for this medication is important for me. Again, because every body is different. So I have to keep going through prior auth because they don't want to cover the brand name. They keep telling me that the generic will work. I said, unless you want me in the ER, it's not working, because it makes my heart rate spike and I could stroke. So, these are the kinds of conversations that I have almost every month with my insurance provider. And I'm lucky that I have the wherewithal and the knowledge to make those arguments with my health plan. But, managing a chronic disease is a full-time job anyway. Arguing with your health plan provider is even more so frustrating and time-consuming. And also costly for both my time as well as the health plans. So really streamlining these processes is a money saver, but it can be, an uphill battle in states where bigger reform conversations are coming with a high fiscal note, or talking about any kind of mandate on a health plan, and any type of state-regulated coverage comes with, well, what is the expense? I always think it's really eye-opening to see the expense versus the lives conversation anyway, but really whenever we're talking about this, I start to add up all the time it takes to navigate these utilization management protocols that are intended to save money, but actually contribute a lot to it. So a lot of our efforts, again, have been to streamline those processes, make it more transparent, especially whenever it comes to the patient's knowledge and the provider's knowledge of the processes that are necessary. And then, hopefully push towards, federal reform as well. We have the Safe Step Act, which has made progress as well. I will say, caveat, I am not a federal lobbyist. I'm a state lobbyist, so I don't have all the details on that. But my colleague is on the next panel, so she probably will have more information for you. But this is definitely a high-level priority for us, and I see reform over step therapy, over prior authorization increasingly becoming the subject, especially whenever it comes to kind of these navigating switching plans and between states, commerce clauses, et cetera. If you are going for care for a rare disease, sometimes you do need to travel outside of state. So there's a lot of details in that over who picks up the tab and how far your plan extends. So just a lot of great work to be done, but a lot of education as well, because I don't think a lot of people understand, until you face a chronic disease and really utilize your health plan, where the barriers are in your coverage.
Well, there's a lot to unpack there. I actually, in full disclosure, work for the largest multi-state nonprofit Medicaid plan in the country, CareSource, as their EVP of Business Development. And I can tell you that from a payer's perspective, this is a real challenge because the diagnosis of a rare disease is generally not a straight line. And it is generally very challenging for the plan that's managing a lot of people to pick that out and suss it out. And that's really goes to a question I wanted to raise around the biomarker testing issue. I know our last panel chatted a little bit about it, but I wanted to raise it again because, again, as a payer, this is a unique challenge. Yes, it has the possibility of saving money, but as a payer, I can tell you almost certainly it will not actually save money because there will be a lot of people that do a lot of genetic testing, all of which is a good thing. So ultimately, it is a cost that states will have to manage in their Medicaid program for those that are in Medicaid or for insurance on the other side. So I wanted to talk a little bit about this biomarker testing and its pairing to precision medication, right? Because that's two sides of the same coin. Maybe you can talk, Melissa, I didn't want to, because you had so much there, I want to unpack a little bit about the group you've been working with to focus on this. And then Patrick, I'd like to turn to you and get a sense about where the companies that are developing these cutting edge therapeutics are. Because I know many of you, there are a couple in this room that know my wife better than me because she's way smarter. She worked at the FDA, and the FDA has a real challenge of approving tools that are matched to the biologic. So, Melissa, maybe you go first, and then Patrick, you give some thoughts on how the companies are approaching it.
Sure. So, whoops. Okay, there we go. I would say, so biomarker testing and, getting access to more precision medicine is a newer policy area for the Arthritis Foundation. Typically, you think of biomarkers, you think of cancer, which I understand. I've been in that world for 20 years. Used to be a lobbyist for the American Cancer Society as well, and heart, and kind of all the major disease groups. So usually you don't think of arthritis or ALS or MS or psoriasis, hemophilia. All of these groups, though, do care about it, and I would say that it's only ever expanding. Being able to take some of the tests that you already do and look at, again, drugs' impact, like methotrexate is a drug that is used across different disease types. So seeing the effect of that drug, which can have pretty devastating side effects, and really curtailing the treatment plan for it based off of a biomarker test is super helpful. Like I said, for the treatment that I had as a cancer patient in high school, they don't do the high-dose radiation to the chest anymore because it's very toxic, and it obviously led to other types of cancer. That's the story with a lot of different drugs. And it's like you find a cure, but there's the domino effect of disease where one chronic disease just naturally leads to another, but also the treatment of that disease can lead to other diseases that you need to manage. So again, streamlining the dosage, the type of drugs that you're putting into your body to treat a disease that can be pretty devastating is really important. So the work that we do has been predominantly with the cancer community, the American Cancer Society Cancer Action Network. In the last year, we have worked, I think we're up to 13 states, and we're waiting for New York to sign a bill. The governor's had that on her desk for like 6 months, so we're still pushing for signature there to get coverage for biomarker testing, but there's a lot of activity still in the states that have ongoing sessions. I want to say there's like 3 or 4 states. And then leading into 24, we have probably 10 target states that we'll be working on. So the more coverage that we can get across the nation, that pushes the dial even further, and again, creates more awareness for what you could do in treating chronic diseases. Again, it's not a one-size-fits-all solution. The goalpost isn't always the cure. It's about treating chronic disease in a way where people can live their lives the way they want to. And sometimes that doesn't mean being disease-free. Like I always say, no evidence of disease is great. I love seeing that on those reports. But I currently still have thyroid cancer in my neck, but I'm here and I'm living a quality of life. So I'm good. Like that's my bar. I want to be in a place where I can work, I can go out in public, and be able to manage my disease the way that I want to. And I think biomarker testing is the way of the future in terms of managing not just cancer, but arthritis and all these chronic diseases. And hopefully the innovation comes along where we can use it across disease types. So there's just a lot of promise there, and we're very excited to work on that.
Patrick?
Yeah, I think, from a manufacturer's perspective, we, obviously most of our members are the companies making the medicines and therapies themselves, but we do have a few diagnostic companies that are trying to develop more precise biomarker testing. And always the goal with manufacturers is to try and do something that is more efficient and done more cheaply. And I think that's what they're striving towards right now. This is a relatively new field. And we've always maintained that, what good is a therapy if nobody can afford it or have access to it? So that's an important thing that a lot of our manufacturers keep in mind. I know on the legislation, we're very active on the state front, helping ACS CAN push these bills across the finish line. We too are waiting with bated breath to see if Governor Hochul will. I didn't see Governor Hochul's daughter-in-law in here earlier, but we're going to push for that bill for her to pass or sign that piece of legislation into law by the end of the year, and hopefully we will do that. One of the things we, as an association, try to impress upon legislators when we're pushing for these biomarkers bills is it isn't just cancer related, and that has been a very difficult hurdle to overcome, because I think a lot of policymakers think of biomarkers only in cancer and they don't realize it is applicable to other therapeutic areas. Admittedly, when you add a fiscal note to a bill, which is like and for those in U.S. Congress, it's like a CBO score, that can be the death knell to a piece of legislation. States don't want to pay for this stuff. Medicaid programs don't want to pay for it because, admittedly, they are taxed under a lot of pressure in other areas. So we have to convince legislators that it is for other therapies, and they kind of want to whittle it down to cancer only, and we're out there trying to fight and tell them that, this is good for other therapies. And I will push back a little bit, I think. I do think these, in the long run, they will end up saving money, because with the objective of one of these tests is to get the patient the medicine that's going to work for them the best. And that, in effect, does save money downstream. But as you know, and people that are active in the health policy world, budget people look in a silo, and they're just very worried about their 2024 dollars and not the outlays in next year's. But suffice to say that we're very much involved in this, something we're very active in pushing in a number of states.
So there's a lot of stuff at the state level on the regulatory side. Let me switch, because I know we don't have a lot of time, but I do want to switch to the Medicaid side, because as a payer, the states have enormous leverage on access and coverage. I know from my experience at Curafi that one of the challenges that plans and states have for rare diseases is, by definition, they are rare, and the need for service is very expensive for those rare diseases. And if you know anything about math, you know that high variability and high cost create a very difficult way to manage costs, especially where states have gone to managed care. And that creates its own problems. And we can talk about Arizona. I actually think Arizona really has a unique way to manage this high variability, high cost stuff. But ultimately, I think the challenge for Medicaid is that how do you manage this access and payment issues? States don't have a printing press. They have to balance their budget. So how does this work? And Mac, I know that RAAP has been thinking a lot about how to address this access issue and how to address some of the state shortcomings about getting these products onto formularies quickly so that people can get access. And I'd like to turn over to you to give kind of some thoughts about what RAAP is doing to address these issues.
Well, thank you. I often feel when I'm dealing with state legislatures that I become an extra in One Flew Over the Cuckoo's Nest, because there doesn't seem to be any rational view about how we get to a solution. There's a lot of reaction to the various players in the system, and most of the reaction comes to those people that have the biggest footprint. That would be the insurers, the PBMs, because they develop these relationships. They come in with bags of money, usually called campaign contributions. They influence these state legislators. These people are human beings, and they don't have much expertise in these areas, but they get influenced by these so-called experts that show up at their door. So our problem is that we confront these well-funded opponents with easily influenced legislators who only hear that side of the story. And so I think the challenge we have as a rare disease community is to identify where we can actually give our message. And I'm often asked, who's the best advocate for the rare disease community? I can tell you it's Melissa. It's a patient. It's someone who's experienced it, because it is difficult for a state legislator to answer a patient or a family member of a patient, a caregiver, to say, oh, well, I'm going to make this policy. Easy to tell me that, because I'm just a lobbyist, and we all know what a lobbyist is and all of that. But it's very difficult for them to react in any kind of a negative way, and they listen better. Legislators will be inclined to listen to their constituents, and so the best advocate really is the rare disease patient. The best message is the experience that rare disease patient has had with confronting the challenges of getting access to care. And we know that the formularies are a huge problem. We know that the barriers that states have defensively erected because of the limitations on funding, with, as I mentioned earlier, this huge pipeline of new therapies that come on board, they're available, but they're not financially accessible. And so the state Medicaid directors have to erect barriers, and we need to break those barriers, knock them down. We need to just be done with them, but then you end up with the PBMs and the insurers. I know that we've worked at RAAP pushing hard on copay accumulator and maximizer reforms. That's needed, and yet, and I'll give you the case study, in the state of Utah, one of the leaders of the House of Representatives just completely scuttled the copay accumulator bill because he was told by the PBM representatives, lobbyists, and the insurers that it was going to drive up the increase in premiums of all of the other payers. Now, that's an interesting argument, because the only way that would be true is if the PBMs and the insurers had taken money that wasn't theirs, which was, of course, the copay accumulators. And this legislator, who's a very bright guy, sat in a hearing in the House side and said, my concern is that these innovator companies will give the pharma companies, he didn't call them innovators, pharma companies will give 15% of the cost of the drug into copay accumulators, but they get to keep 85% of the money. I thought, what is he talking about? So what? The innovator company that invested in the research and development, that took the risk to develop the therapy, should get 100% of the money, and he's begrudging them getting 85%. Now, this particular legislator is a home builder, and I went up to him afterwards and I said, look, if you were forced to give up 15% of the value of a home in order to contribute to a low-income housing fund, would you like that? He goes, well, it depends on the circumstances, but no. I said, what if we took 100% from you? You couldn't have the 85% that's left. He goes, that's ridiculous. And of course it is. Of course it is. So that's the challenge. We have to re-educate these legislators, reposition our argument, and make them understand. Now, I had a great conversation with this legislator / home builder later, and he hasn't abandoned he called it hatred of pharma, right, which is misplaced, but he hates the PBMs now just as much. And so at least we've got him redirected and channeled that energy, because there needs to be PBM reform. And I think one of the speakers earlier said PBMs had their place early on, but they have now so warped the environment that now they're just a cash cow. And they're taking money and absorbing it, and they're spreading it out among their own operations and among the payer, the insurers, that it's now become such a bastardized system we don't even recognize it anymore. You no longer serving those clients. So I think that going forward, we're making progress in the states with making these arguments about patient access. And we're winning in most states where we're able to get in front of legislators, tell this story with advocates doing it for us, and that's where RAAP is focused. And I think we're going to continue to have success there. We need to empower patient advocacy organizations, diffuse where we can the tension between the innovator companies and the patient advocacy groups, because I know that exists. I understand it. I know that there's resentment among some of the patient advocacy groups towards the innovators, but I think a better understanding there will smooth out that relationship and allow us to speak with a louder voice. And one of the great things that RAAP has done is that we've gone into the belly of the beast, and that is we've gone to the National Conference of State Legislators, which has, for the last probably decade or so, really tilted towards the groups like the Commonwealth Fund and the Arnold Foundation, who are all just data aggregators, and they look at the thing in the big picture and they say, oh, healthcare problems are all because of these high-cost drugs. And they will not recognize or accept the idea that development of a rare therapy requires a lot more investment and risk capital, because you can't amortize the cost over a larger population for those things. But they don't segment it in any way and don't recognize it. NCSL agreed to do a special project with us that will over the next year, as a pilot, look at that closely. In fact, we have a meeting set up in August and early December where we're going to have a group of 25 to 30 legislators from across the country who are healthcare committee chairs or vice chairs who are going to hear this message and explain to them why patient access, reducing financial barriers, recognizing that the care is not just financial, but the burden on families is far more dramatic than that, and that they have to accommodate that as they evaluate their public policies. We think that's a great step forward, and the interesting thing has been the acceptance that NCSL has given to this. We worried that when we set up this first meeting that they would populate it with our enemies, and they haven't, which tells you that the message resonated, and we're going to have great progress, we think, in this pilot. And then I think we need to energize that, fill the pipeline with more information, good patient advocacy, and we're going to make a dramatic difference going forward in repositioning this whole argument that somehow innovator companies and patient groups, advocacy groups are somehow at loggerheads. No, we're aligned when it comes to the issue of making sure that we allow for these incentivized rare therapies that the federal government created the pipeline for actually get to the patients who need them and use them and who will benefit from them.
So I want to, I'd like to piggyback on that discussion around the drug companies and the need for a real return. Right before, after I left Congress, I worked for 4 different drug companies for a decade and actually got my MBA to talk about how drugs get priced and why they're priced the way they are. And so, Patrick, I'd like to end with you before we turn it over to the audience to talk a little bit about the challenge that it takes for companies to develop products in the small population space, right? You have to get a return or that stuff is just never going to get developed. CMS is trying to address this in Medicaid, looking at the cell and gene therapy access model, which is probably going to be targeted at sickle cell disease. That, I think, has both positives and negatives. And so I'd like to get a sense, Patrick, from you about where Bio and the companies are thinking about this innovative approach from CMS and what are other reimbursement structures that the companies can do to make sure that there's continued pipeline for people who don't have therapies.
Right. Thanks, Jeff. Yeah, so CMS has come out with sort of 3, I would say, demo projects, and one is around gene and cell therapy. It's a gene and cell therapy access model where it will be a collective, it'll be a multi-state outreach where they'll work with several state Medicaid programs on outcomes-based arrangements. And that's something our companies support. I mean, we want to stand by our products. We know they work. So right now, I think there's some unanswered questions right now. I think the big one out there is for the policy wonks that are out there. You know, CMS has released a proposed rule on how they're going to restructure the Medicaid drug rebate program. And there are some very significant changes in that. And we have some companies actually looking at that saying that's a bigger deal than IRA maybe because of the fundamental changes it's going to have to the rebate that manufacturers pay to the Medicaid program, or CMS rather, and Medicaid program. So that's a big question, like how is this demo project going to fit within that new construct? So I think manufacturers right now are we're waiting to see and trying to get a little bit more information. And we do think it's going to be focused on sickle cell. They've also mentioned cancer, but I do think it's going to be mostly sickle cell. So we're kind of in a wait and see mode on that. I wouldn't say we are opposed to it. I think it's just we're a little skeptical right now on how it's going to work. One of the other things that we're working on in the States, and you know, we convened our gene therapy companies to talk about what's the Medicaid access landscape look like. And one of the ideas that came out was how can we work with states to push innovative payment models, outcomes-based arrangements, value-based arrangements? How can we convince state Medicaid programs to look at those as alternatives because these therapies don't fit through traditional Medicaid fee-for-service model, which is more applicable to therapies for chronic diseases. And we've had some success. We've passed legislation in Texas. We've passed legislation in Ohio, Minnesota. We're going to some other states. I think we're looking to work on a bill in Wisconsin. And but to your point, this takes a lot of educating. This is I wouldn't say it's a new concept for Medicaid programs, but Medicaid programs, I think the more sophisticated programs get it and they understand the need to do something like this, and there's a willingness and a receptivity. I think in smaller states, they look at these arrangements a little bit with a jaundiced eye because they've not entered into them yet, and they recognize there's a lot of back-end work that has to happen because you've got to track patients to see how they're doing and see if the therapy is working. So we're educating a lot of Medicaid programs right now on that. So we have a network of 48 state affiliates, and we're working with each one of them to do these briefings on genomics medicine and then weave into that discussion these innovative payment models. And our stance is, this has to be a voluntary process. The arrangement has to be something that both the Medicaid program and the individual manufacturer have come together and agreed upon, because each therapy is different, patient populations are different. And I admit, our companies have done a really good job of thinking outside of the box on how to get some therapies out to patients, giving new innovative payment models. That's one area that we're working on. Another area that we are working on is we call it our Medicaid best practices effort. And this is looking at states where the Medicaid P&T committee process or drug utilization review board process is challenging or not as forthcoming as it ought to be. So we're working with states to figure out. And admittedly, you have state Medicaid programs that are slow walking some of these gene therapies because they recognize there's a cost, and they're taking their time providing coverage decisions on these therapies. So we are trying to push either through legislation or through regulation rules that require a state Medicaid program to have someone from an RDAC sit on the P&T committee process, or at least have a clinician who treats rare disease patients sitting on these review boards that can provide some expertise on how these therapies will be used. Also, simple things like posting when a Medicaid P&T committee or DERB committee is going to meet ahead of time, so that and allowing manufacturers to come in and present on their therapy and why that therapy is a value to the system. It's simple things like that we're working on. You would be surprised at some of the states where this is not an easy thing to do. So that's what we're doing in that area.
Well, that's good to know. We have some time before I have to turn it over. Are there any questions or thoughts?
Jeff, could I add one other thing
yes, sir.
off of what Patrick said? I think that this focus on drug pricing is really the ground floor of our problem, because everybody looks at that and says, oh, we've got all these terrible high prices. And what do inevitably? They contrast it to what drug prices are in other countries. And they say, look how high they are here. I represented the United States at a group called the Ditchley Foundation in Oxford, England in the mid-'80s. And all of the heads of health policy in those countries, many countries were there. And the leaders from Canada, England, Spain, Portugal, Germany, Switzerland, and Japan all came to me and thanked me. They said, thank God for America, because you have a drug development system that allows us to take advantage of all of the new therapies that we are saving lives with in our countries. And do you know what the difference between our system and theirs is? They're price controlled, right? And when you hear these people talk about, oh, well, we can import these drugs from other countries at those levels, they're not importing the drug. It's the same drug, unless it's been, of course, counterfeited. The difference is that we're importing price-controlled products. That's all. One of my dear friends in the world, and I admire him greatly, is Bernie Sanders. He believes in these we can import these drugs back. He's importing price controls. And we have to use the tools that are available to us in the United States to make sure those countries do not take advantage of this system that makes the American taxpayer bear the burden of subsidizing the drugs in other countries. And we should take care of our own patients in this country. And if we do that, if we force them to pay their fair share, then you'll see drug price reductions here, and you'll see more money in the system that will allow for the treatment of rare disease patients, among others. And this is an important thing that we need to get public policy people at the federal level to understand.
So if I can add a little snark as a former payer, if everyone were really worried about drug pricing, what they'd really be worried about is the unbelievable inflation rate of hospital services.
Yes.
There are no hospital guys here to throw stuff at me, but the data is overwhelming that short of the rapacious increase that colleges have, I know I have two, in college. It is literally only seconded to the inflation rate of inpatient hospital services. So there is that too. But that's just me and a little snark. Yes, sir.
Listen, I'm glad you said that as a former payer, because drugs account for about 22% of healthcare spending.
Yep.
So payers have done a wonderful job at demonizing biotech and pricing. There are bad players, we all know that. But yes, inflationary. My brother is a chief of surgery, and he gets paid a shit ton of money. He gets more, excuse my expression, but yes. And when an aspirin costs $32, right? There's other issues. But elected officials are just as likely to lie to me as they already do. Listen, I was sitting with one of the deepest red kind of guys who was looking me in the eye and saying, I'm for Medicaid expansion. Right? So they'll lie to anybody. They'll take your money and then they'll turn around and stay back. So it doesn't matter who it is. The other thing I would tell you is get John Crowley to go sit at Kathy Hochul's office so she signs it, and he'll get it done.
Yeah, John's a force to be reckoned with, that's for sure.
Although we were just talking about this earlier, about the inflation costs in terms of education and hospitalization, and I was able to draw across the fact that I had children over many years, and so when I had my first child in Detroit, it cost me $13.10 when I left the hospital. That was my bill in 1981. And what a difference that was 25 years later. And how our parents and the generation before us, we didn't talk so much about the bills. We were worried about the bills. I remember my parents being worried about bills or things like this, but it didn't break their backs. And they were blue-collar workers in Detroit. And look at where we are today. And I don't know what that answer is, and I don't know if it's for today, but there's something here that tells us we are way beyond where we should be in terms of how our economics have moved. Escalation of hospital costs, education costs is far surpassed. How can we ever catch up to that? That worries me.
Great.
So if I could add to that, so before coming to the Arthritis Foundation and in between my personal passion and efforts as an advocate and cancer survivor, I worked for the National Association of Realtors, and often we talked about, for 8 years, we talked about your home being your biggest investment, and I always would say, that's not true. Your body is. And I can give an example of, having a mortgage, basically a payment for one day in the ICU once, whenever I was on a vent in 2014, and I got a $111,000 bill for just one day of being on a ventilator. So I totally agree with you whenever it comes to the price and where the actual problems could be that are on the higher end, that are that mortgage level. I also have a very good friend. She got the flu in 2014. It was a rough year for both of us. And she ended up going on ECMO and had to have her left leg amputated above the knee. So she was 36 at the time. Obviously, this is a forever condition, although her insurance companies have insisted on prior authorization for that prosthetic every single year. She's always says to them, my leg's not growing back. I'm not a lizard. It doesn't work that way. But when she was first getting her leg, the cost of her prosthetic here in America, especially because she was above the knee, that knee is very expensive, was over $100,000. She, as a non-dual national, went to Germany and got a leg for $6,000 as a non-citizen, which would have been covered completely had she been a taxpayer there. But again, you look at the two systems and you can't compare it because you have one buyer and one health plan basically to navigate in other countries, and you have many health plans to navigate here, and you have state-regulated care and you have federally regulated care. And if there's anything that we learned from bigger reform efforts like the Affordable Care Act, is you have to work on both levels of government. You have to codify things into the state level, as well as work on the federal level. So like with the copay accumulators, we've been successful in 19 states, DC and Puerto Rico now, and we actually this morning made it out of Ohio's committee, which if you're interested in watching the debate on this issue, that hearing the last couple weeks with opposition as well as proponent testimony was very interesting and kind of covers the whole gamut of what copayment assistance looks like in this country, especially with those that have a chronic disease that are on high deductible plans. There is no generic alternative in a lot of cases, and rely on not just manufacturer assistance, but foundation experience or dollars and other third-party assistance. And this taking from either the PBM or whoever it may be is akin, in my book, to a contract infringement. Like, you are awarded a scholarship and you try to apply it for your tuition. They take the payment, but your tuition bill doesn't go down. And you're still responsible for that for the year. So you're in copay quicksand and you can't budget. So if the argument is always for patients to be responsible to budget for their health care, well, it's nearly impossible if you're facing a chronic disease in this country because of those high medical costs, not just because of a drug that might be life-saving but is innovative and still new, but especially because of the actual care that you're experiencing in a hospital or other healthcare setting. So there's a lot of angles that you have to navigate in this country, and I think it's unfair to compare it to other countries because our systems are so different. But at the same token, emphasizing the patient experience and turning that into the policy change, I think is where policymakers have to focus, and that's on both levels of government.
And with that, that's a great way to end. Mike, I'll turn it back over to you. Thank you.